A diabetic foot in private practice, foot screening, assessment and management of the diabetic foot. Before we start, please take a few minutes to fill out the pre-training questionnaire. Thank you. Who are we? Well, my name is Georgina Frank and I'm the Deputy Director of Podiatry for the Sydney Local Health District, and I've worked in high-risk foot for approximately 18 years. This is Panema Rayo. She's a Level 3 podiatrist based at the Royal Prince Alfred Hospital and Concord Hospital High-Risk Foot Services, while also working in our step-down clinics in our community services for patients requiring ongoing foot care. What are we and why do we do and why do we care? All right, so we're podiatrists. We work in the spectrum of podiatry. But in today's talk, we're going to talk about high-risk feet and how to prevent or at least manage diabetic foot ulcers, amputation prevention particularly, and then the specialist foot care services to implement preventative care. But why do we care? Well, Fred is the reason we care. So Fred presents to the Canterbury Hospital Emergency Department feeling sick. A week ago, he cut his foot in the shower. There was just a bit of blood. It did not hurt, and though he was a bit worried that the plumbing had been playing up, so that his feet had been in dirty water that had backwashed into the shower stall, he didn't worry because his feet didn't hurt. A few days ago, that had begun to change. But he had put on a bit of weight and his eyes weren't so good, and he could not see what the problem was. He waited until his daughter came over the next day to look at his foot. She said that there was a cut and it was red around the area. She washed it with warm water and put a band-aid on it. She thought he should go to the doctor just in case. He saw the doctor this morning, and this redness had gotten a lot worse and travelled up his leg. His diabetes was also worse than normal, and he felt like he had a bad case of the flu. His doctor sent him straight to the emergency department. When he asked the doctor if he could just have some antibiotics, the doctor looked very worried and told him that the infection looked like it was in his bloodstream and he needed antibiotics that would be administered with a needle. When he finally sees the emergency doctor, the doctor takes the dressing off and squeezes the fourth toe of the left foot. Pus comes out. The doctor then uses some tweezers to prod around the toe, and they go in quite far. The doctor says that he probably needs to have the toe cut off. Fred and his daughter are frightened. They know diabetes is bad, and the family members have had amputations before, but they did not understand why it was happening to him. The burden of diabetic foot disease. So this is a common presentation for diabetic foot disease in our hospitals. We know that 1 in 5 people with diabetes will have characteristics that predispose them to amputation. Australia has the second highest amputation rate in the developed world, and it impacts not only the amputee, who may have to cease working and providing, but also their families and carers as they have to take on the individual's responsibilities. But we have to remember that based on our evidence, the state, national and international guidelines advise that these outcomes are preventable. Amputations are preventable. Yet many of our patients continue to present with little knowledge regarding the risk characteristics that may have contributed to the development of foot complications. Confusion is also reported by community and tertiary care healthcare practitioners regarding referral pathways and resources that are available to support and educate patients. And part of this confusion is when and whom we should refer to. Now, today we've got real opportunities to improve these outcomes through early intervention via foot screening, assessment and management through referral. We'll discuss what resources you have available and what constitutes timely referral. Our responsibilities to improve the health outcomes for our patients with foot pathologies will be explained, and simple but important assessment tasks will be practiced. But what's your responsibility as a healthcare practitioner? Well, the evidence suggests that providing at-risk and high-risk patients with regular appointments to promote education, recognising potential problems earlier and implementing appropriate care plans with multidisciplinary teams can reduce the incidence of foot ulceration. This has been proven to be a cost-effective strategy to reduce amputation. But first we need to identify who is at risk and high risk of developing foot complications. This is done through risk stratification. Risk stratification. You have a copy in your information booklet. A screening system facilitates the implementation of a management plan. You'll find a copy of the risk stratification tool we utilise within the Sydney Local Health District. By identifying the risk factors that predispose someone with diabetes to developing foot complications, we can make a prediction regarding their risk of developing a foot ulcer or amputation. To prevent this outcome, a suitable management plan needs to be implemented. So the foot assessment process, we've got a handout in your information booklet which will help. To stratify a person's risk of developing foot complications, the exam consists of 3 components: taking a patient history, performing a physical exam, which comprises of dermatological, neurological, vascular, musculoskeletal exam, and providing a patient with education based on the outcome of the first 2 components. This outcome is essentially their risk rating and will inform your decision on whether and to whom to refer the patient. But what are the risk factors commonly associated with foot ulceration and amputation? Let's go around the room. Each person tell me at least one risk factor, and Panema will write them down on the whiteboard. How did we do? All right, so previous foot ulcer. As part of a thorough patient history and following through with a physical exam, knowing what a patient has had and whether a patient has had an ulcer or an amputation is predictive of future ulcer reoccurrence. A previous ulcer or amputation is highly predictive. Always look at both feet, but remember to ask the patient. It can be awkward trying to pull off a shoe on a prosthesis. We've also got socio-demographic considerations: poor attendance for foot care treatments, lack of compliance with footwear, delay in seeking treatment, being male, alcohol intake, and consider that our Aboriginal and Torres Strait Islander patients who have a 4-fold increased likelihood of peripheral neuropathy and diabetic foot problems which occur at a younger age. Rates of hospital admission for diabetic foot ulcer are also higher as are amputation rates. This indicates that they are presenting to seek help at quite an advanced stage of infection. We have to consider why this is happening. End-stage renal disease is another risk factor. Callus and deformity. So deformity alone is not a strong predictor of diabetic foot ulcers. However, deformity plus peripheral neuropathy equals foot ulceration. For instance, a shoe not fitting properly. Deformities include a Charcot foot, so from Charcot neuroarthropathy, bunions, clawed toes, iatrogenic deformity, so some drugs can cause a peripheral neuropathy, or some sort of deformities. And remember, limited joint mobility or stiff joints contributes to increased plantar pressures and has implications for treatment. Footwear. It's really important to always check footwear for pressure areas, rubs, and a good fit. It's awful when 50% of our ulcerations come from a bad shoe. And also there's a huge risk of falls injury in a shoe that doesn't or flops around. Now, we also have to look at common skin lesions. Tinea pedis is often misdiagnosed as just dry skin. A urea-based cream can help allow the antifungal penetrate, so it's important to follow both these processes. Fissures are commonly cause ulceration. Peripheral neuropathy causes anhydrotic skin or dry skin. Peripheral arterial disease causes loss of skin integrity. Glycosylation makes the skin stiffer. And to prevent this, we use heel balms and footwear with enclosed heels. You want to refer to a podiatrist for debridement of associated callus to manage open fissures, as wounds without debridement, as open fissures as wounds, and debridement and mechanical support and dressings can manage this. Patients on bed rest need to have pressure taken off their heels. Now, peripheral neuropathy. This is highly predictive of ulcer risk. It's one of the most common microvascular complications in both type 1 and type 2 diabetes. It's been defined as the presence of symptoms and/or signs of peripheral nerve dysfunction in people with diabetes after the exclusion of other causes. It's the most common component in the causal sequence to foot ulceration. Typical peripheral neuropathy is a distal symmetric sensoriomotor polyneuropathy, resulting in sensory loss, unable to detect pain, pressure, or heat, motor impairment, deformity, increased plantar pressures, and autonomic dysfunction, leading to loss of sweating and blood flow changes. Please turn to the instructions on using a monofilament test in your booklet. It's in neurovascular. The Siemens-Weinstein monofilament is a well-documented test for predicting ulcer risk, and it's long been advocated as an essential component of a thorough foot exam. It's important to remember that the patient needs to have their eyes closed when the test is being carried out. Peripheral blood. We tend to recommend Bailey's retractable monofilament. That has been shown to be reliable, but you've got some disposable monofilaments in your pack today. In type 2 diabetes mellitus, the absence of at least one dorsalis pedis or one posterior tibialis was associated with the increased 5-year risks of major macrovascular events, myocardial infarction, stroke, major macrovascular events, nephropathy, end-stage renal disease or renal death, peripheral neuropathy, and all-cause hospitalisation. The strongest risks were observed in patients with the greatest number of absent peripheral pulses. Please turn to the vascular assessment instructions in your booklet. Pulses should be done in an unhurried clinical setting, as this has been shown to more accurately diagnose peripheral arterial disease. If you are not confident palpating or suspect peripheral arterial disease, consider referring for vascular studies. Many podiatry services now use a handheld Doppler and may request formal studies if they're concerned. Know that if you find no pedal pulses, you should be highly suspicious of peripheral arterial disease and consider referral to a vascular surgeon. Now we're going to do a 20-minute practical hands-on. We've set up 2 stations where you'll take turns palpating pedal pulses and assessing for peripheral neuropathy with the monofilament. Please use the disposable monofilament on your table. How does this information help and why does it matter? Before going into the more meaty etiology and management aspects, let's have a look at the Sydney Local Health District Risk Stratification tool. Please look in your booklet until you find the table. For this session, I'm going to give you the risk factors identified after a foot screening, and you will write down the patient's risk score. This lady comes in. She's unable to feel the monofilament and she has a foot deformity. What is her risk score? She is at high risk of developing a foot ulcer. This gentleman comes in. He has long toenails but no other risk factors. What is his risk score? He's at low risk of developing a foot ulcer. This gentleman comes in next. We are able to palpate his dorsalis pedis, but unable to palpate tibialis posterior. He's unable to feel the monofilament and does not have any foot pathology. What is his risk score? He's at risk of developing a foot complication or foot ulcer. You all know what it's like wearing a pair of uncomfortable shoes, developing a blister and agony until you take them off, or standing on sand or concrete in the peak of summer and then hopping about to find some relief. Patients with neuropathy don't have that warning system. I have a gentleman who came back from Sri Lanka with 3rd-degree burns from visiting temples. I've just been there. It was agony, and after a few seconds I was fishing socks out of my backpack. He just went on walking bare feet, walking and burning, unlike most people who look for shaded areas. Once an injury occurs, healing may be impeded by poor blood supply or elevated blood glucose levels, which impair the function of white blood cells in fighting infection. The wound is then exacerbated by further callus development, which grows in response to pressure, which adds further pressure, especially when you consider the deformity that happens in the presence of neuropathy, where there's contraction and fat pad is lost, and so bony prominences occur. This creates a cycle of trauma which slowly undermines underlying structures and tissue, eventually damaging bone, resulting in the need for amputation due to infection. Now, we get this awful lot. You've made the wound bigger and it's bleeding and it looks worse. This is a very common question that high-risk foot services and podiatrists get from patients and other health practitioners. Why do we want to convert a chronic wound to an acute wound? Well, sharp debridement stimulates the edges of the wound, releases growth factors, and reduces inflammation. It also removes dead, diseased, and infected tissue to allow healthy tissue to grow and heal. Eliminates the conditions for bacterial overgrowth and other disease processes that could lead to pain, sepsis, and eventually amputation. So, for instance, our steps are: we establish etiology, we sharp debride if indicated, we establish depth. If it's probed to bone, there's a high suspicion of osteomyelitis. We make a dressing joist to maintain moisture balance, and we generally refer to a baseline X-ray at our first appointment. But how does debriding reduce pressure, and why do we bother? Well, pressure is the major cause of trauma. Offloading essentially attempts to remove external pressure from the ulcer site to protect and support tissue healing. The evidence to date suggests that weekly to bi-weekly sharp debridement. So sending someone to a private podiatrist every 6 weeks is not best practice, but it's not unusual. The average time for someone to have an ulcer before coming to our service is approximately 16 weeks, which is concerning as most of the data to date shows the outcomes are worse the longer the ulcer is. And this goes against the reality that a multidisciplinary team on average heals ulcers and expect ulcers to heal within 12 weeks. But how else do we relieve pressure? Well, sharp debridement is coupled with offloading modalities such as total contact casting, removable knee casts, healing shoes, chairside devices such as temporary orthoses with significant felt deflection, which are also used depending on the ulcer, site, mobility, and cognitive state. Patients with diabetes and foot ulcers need a team-based approach as they are complex and their disease is equally multifaceted. A high-risk foot service provides specialist podiatrists that look after the foot and implement advanced wound healing modalities and offloading techniques. There is medical governance for infection management, either orally, by a hospital in the home, or admission in case of systemic failure. Nursing and medical support for diabetes management is also an important component, as we know that control is affected during times of stress and infection. Psychosocial support is utilised with other allied health professionals like psychology and social work, used when and if required to provide a holistic approach to patient care. For your information, we've also included current antibiotic therapy guidelines for diabetic foot infection in your booklet. These may assist you in your decision-making process. And remember that your local high-risk foot service and microbiology team can provide more detailed information if you require it. Just call. We then also have surgical intervention, which is also readily available with shared consults held with orthopedics and vascular when optimization is required for healing. This does not mean amputation, but rather foot salvage surgery to improve or reduce deformity contributing to the ulcer formation. In the case of orthopedics or revasc, where the primary concern is vascular disease, depending on whether it's impeding healing. I'll get to turn to our risk summaries at the back of your booklet. All right, so knowledge does not equal behaviour change. So how can we help someone change their behaviour? We all know that we need to do at least 30 minutes of exercise or have at least 5 serves of veggies. But do we do it? Can I have a show of hands? Not many. Education is our main way of informing and giving the patient the tools to reduce their risk of developing complications. But experience suggests that this is not a simple proposition. And the research tells us that consistency, reiteration, and providing individualized, meaningful messages that are important to the patient are key aspects to developing a foot protection plan. But there are things we need to consider. We need to explain what a person's risk status means to them, but we need to meet their needs and not our own. For example, if someone walks barefoot to the bathroom each night and regularly injures their foot, we need to make it easier and work out how to make it easier for them to change that behaviour. For instance, why aren't they wearing the shoes? Well, we find out the slippers that they normally wear are too loose and they've not been able to find something that fits their foot properly because they have a bumpy foot, but also allows them to keep their shoe on and know that it's on, because in neuropathy, Sometimes you can't tell if the shoes come off. So we need to look at getting a pair of slippers that are easy to put on at night and that they'll have next to their bed each night. You need to keep the changes small and revisit them at every appointment, adding more as they complete the ones they have. For instance, once they are wearing their slippers all the time, we might try and build on that and work out another area which might be compromising their foot health. We need to ensure that this is an individualised foot protection plan, so it will reflect what the patient wants and what they need. And we need to document to make sure that it reflects what they agree to change. And lastly, we need to be consistent in our messaging. So we need to always say pretty much the same thing. And this can be expanded. If, for instance, they're going to the high-risk foot service, they've been advised to non-weight bear on their ulcer, except for going to the toilet, or if they are going to the toilet, they've been asked to wear the shoe that they've been provided with or wear a prefabricated walking boot. We need all healthcare practitioners and family members in their lives to reinforce that message and be consistent. So everyone needs to be included in this process. There are so many conflicting bits of information nowadays with the internet, helpful friends, helpful newspaper articles, that we need to maintain a consistent and clear message that is not difficult to follow. We also need to make it easier for our First Nation peoples to make changes, and we can do this by accessing care coordinators and supplementary funding pools through the Indigenous Australians Healthcare Program. You'll find an information sheet in your booklet which outlines and gives you contact details for your local integrated care providers. It's these simple changes that can make an incredible difference and ensure equity of access to all our patients. Now, before we start our final practical session, let's discuss recommended referral pathways based on risk. If a person is identified as having a high risk or at-risk foot, regular podiatry review can significantly reduce the severity of poor outcomes. Tertiary and primary care podiatry services are available, and you want to consider whether vascular input is needed where pedal pulses cannot be palpated confidently or as recommended by the patient's podiatrist. If, however, a patient is identified as having a low-risk foot, they are considered to be at no more risk than someone without diabetes. Education and diabetes management is key in this situation. Generally, we should refer when a foot ulcer has been present and not healing for at least 2 to 3 weeks. Our national, state and international guidelines clearly state that interdisciplinary teams provide the best management options to heal diabetic foot ulcers, and we know that the earlier they present, i.e. the shorter the ulcer has been present, the better the outcomes. Now we are going to put it into action. Turn to the back of your booklet and you'll find 4 case studies with blank headings: risk factors, risk management, management plan, education advice. You'll have 5 minutes for each scenario. Write down your answers and any questions you may have. Know your foot screening pathway. You want to establish the risk status. Use the information you have found from the patient history and physical examination to establish the patient's risk of developing a foot ulcer, and use this information to tailor an appropriate management plan, including who to refer to and what education is required. You want to provide relevant education. You want to keep the message simple, clear, and individualized, and build on it with each assessment. You want to know when and to whom to refer to. Don't forget that most services are happy to chat about possible referral or will accept email or fax. Before we all go home, please take a few minutes to fill out the post-training questionnaire on your desk. Panima will point out our specific one. Thank you.